Hi, I'm Jack with Dose of Pharma, and today I'm sitting with Amanda Cross, Dr. Amanda Cross, rather. Amanda's completed her Bachelor of Pharmacy and become registered in 2010, so she's quite an experienced pharmacist. In fact, being an accredited HMR and RMR pharmacist. She's completed a PhD as well, looking into topics surrounding better medicine use in patients with memory impairment. She's a current PSA board director, a research fellow, and fun fact, has been at Chemist Warehouse for 16 years now, starting as a student and now being a pharmacist in charge. Is that right, Amanda?
So I'm not a pharmacist in charge anymore, but
Okay.
I still am, yeah, sort of a part-time employee with Chemist Warehouse. But yeah, the rest of it is accurate, and yeah, sort of quite a varied experience in various different forms as a pharmacist. Yeah.
Excellent. Yeah. So do you want to just to start off with, I suppose, share a little bit about your experiences in pharmacy and what are maybe three or four things that have happened in your career that have led you to where you are today?
Sure. So, as you sort of said, yeah, I did my intern year in community pharmacy. I've had over 10 years of sort of experience in community pharmacy. Soon after registering, I completed my accreditation to become a consultant pharmacist. And that was really sort of a passion to help people a little bit more and sort of being able to spend that bit more time to help them with their medications. So, being able to go out to their homes and review their medicines and make recommendations and be, I guess, a little bit more involved as part of their healthcare team. And through those sort of conversations, both in the community pharmacy and in those home medication reviews, I started to see, I guess, the same patterns of medication use and particularly inappropriate medication use. So high uses of sedatives and anticholinergic medications. And that's really what got me into research. Obviously, I could help individual patients when I sort of spoke to them, but really wanting to, I guess, make a difference on a larger scale and really trying to improve sort of resources or look at why people were sort of continually using these inappropriate medications and see if we can make a difference on a larger scale. So that's what got me into a PhD. And also my postdoc research is really sort of health service based and looking at really practical things about how we can help healthcare professionals and consumers use their medicines more safely and more appropriately.
Yeah, it's a really important topic. I know from personal experience of having a 99-year-old grandfather in a care home, and just even the difficulty of him having clear for example, I distinctly remember he hadn't been where he is now for more than a week when he had clear bacterial conjunctivitis, and just the hurdles we had to go through to get him quality guide jobs. Where I was like, oh, I know a pharmacist attached to the home could have come in and diagnosed it just as easily as he did as my pharmacist at work. But I suppose, yeah, that sort of thing in my experience is like my family has quite a background with a myriad of illnesses, and that's kind of what's got me into wanting to study pharmacy. But I'm interested, Amanda, at what point did you realize you had that passion for pharmacy and healthcare? I know you spoke a bit on what's driven you to where you are today, but what got you there in the first place, I suppose, is what I'm trying to ask.
First of all, congratulations that you that he's 99. He's definitely done some things right in his life. But I guess I mean, I think one of my earliest memories is probably getting jelly beans at the pharmacy. Maybe that like positive reinforcement is what got me into pharmacy. I don't know. But I guess later on, I guess through school, I had real passion for science and sort of problems and sort of trying to find answers and solutions. And then in high school, expanding that with biology and chemistry and the wonders of how everything works. I think pharmacy was sort of a natural extension of that. Obviously, being able to solve problems and help people and find the best medicine that works the best for that person, but coupling that with actually being able to make a real difference for people as well. So I think that's probably, yeah, that sort of combination of wanting to help people, but also that sort of puzzle solving and understanding how things work was probably what got me into pharmacy.
Yeah, so did you go straight out of high school into pharmacy? Is that right? Okay. Yeah.
Yeah, I
See,
did.
yeah, see, I'm a bit different where I'm in the grad entry pathway. So yeah, I did my biomed degree, my science degrees because I loved my biology, my chemistry, and my physics. But then yeah, didn't quite make the cut for medicine. So I was like, what else can I do? And now I'm studying pharmacy and I'm chuffed. It's never a career I thought I would have done. In fact, I didn't think it was something I could do when I was doing year 12, which is interesting. But yeah, like yourself, it sounds like I also have quite a passion for research, and I've only been a pharmacy student for 8, 9 months, and I'm already involved in a couple projects. And I think it's so important to make sure that, yeah, we have our guidelines and such, but we need to keep updating them, making sure, like you said, you're seeing a lot of like sedative use in aged care homes. So that's something I'm noticing in the classroom. We're addressing that, but of course that had to start somewhere, and I'm sure your research, even your PhD, might have had some influence in driving that kind of how can we better treat our patients, especially those that are elderly with the some memory impairment. But on the note of your PhD and your I suppose our shared passion for research, could you just briefly summarize what your research consisted of in the past and what it is now, and what sort of methods you've employed as well?
Yeah, sure. So I guess sort of like my clinical pharmacy career, I like to do lots of different things. So I've actually done quite a few different methodologies throughout sort of my research career so far. I guess my PhD, as you mentioned, was sort of looking at medication adherence and medication management, and also deprescribing for older adults taking multiple medications, including at that sort of point at which they get diagnosed with memory impairment, or they might start having those symptoms of memory impairment when their goals of care can start to change. So within my PhD, I probably had three sort of core projects. One of them was doing a large literature review, so a Cochrane systematic review. So that was sort of probably the first methodology, and that was looking at intervention, the effectiveness of interventions to improve medication adherence and medication management in older adults taking multiple medications. The second sort of group of projects was we looked at data from people attending memory clinics around Australia, and looked at, so cross-sectionally, looked at what sort of medications they were using, both prescription and non-prescription medications. And then longitudinally, we also looked at what impact those medicines, particularly those inappropriate ones, so sedatives and anticholinergics, what impact they had long-term. And we particularly looked at mortality, so whether they did or didn't increase the risk of mortality. And then I guess the third sort of core project from my PhD was putting all that together. We then did an implementation research, so a pilot study of actually putting a pharmacist into a memory clinic to see if they could assist with deprescribing those inappropriate medications. So memory clinics are sort of multidisciplinary clinics, but there's no pharmacist generally involved with them. So they'll have geriatricians, psychiatrists, nurses, allied health, those sort of things, but not generally a pharmacist. So that was the intervention sort of pilot that we did there, which was actually very feasible, very effective, and acceptable to all the stakeholders too. So that was really exciting. I guess now still sort of working quite similar in that space, but working more in the aged care space, and particularly looking at how do we translate evidence into practice. So if we get a new guideline that says how we should use medicines or what medicines we shouldn't use, how are we actually putting that into practice? And again, still doing quite a few different methodologies. So looking at clinical trials, systematic reviews, co-designing resources with people living with dementia and their healthcare professionals. So lots of different methodologies.
Yeah, I'm familiar with a couple of those myself. I think, yeah, I was writing a systematic review this time last year for my biomed degree, which it's a massive undertaking. So well done, I must
Huge
say.
undertaking. I think we
Massive.
screened like, I can't remember the exact number, but it was over like 20,000 sort of titles and abstracts. Like it was a huge
Oh,
one.
wow. Okay, yeah.
Yeah.
I hope you weren't doing that by yourself.
No, you do it as a pair.
Yeah.
Yeah.
Okay. Yeah. No, that helps. That helps. Yeah. I remember using the Covidence software. I was like, yep, this is a lifesaver.
Yeah.
But yeah, for on the note of your PhD, I suppose you already talked about, you notice these patterns when you're doing your HMRs and RNRs. But I suppose was there any incidents or like a patient in particular, or just any time or event in general that kind of made you click and say, I need to do a PhD and I need to do it in this topic?
Um, I think it was sort of a combination of seeing that in clinical practice and then starting to reach out to a few researchers here at Monash University to see what types of research they were doing and whether it aligned with that sort of interest and passion. And when I met with my two, what were ended up being my supervisors, so Rowan Elliott and Johnson George, they actually had that sort of existing data set of memory clinic patients, and they had all the medication, but no one had looked at the medication. And I'm like, oh, this is perfect. Like this is a great start. And then we can learn from that and then sort of do that implementation work. So it kind of just happened to align very nicely with what I was seeing and sort of the passion that I had in trying to improve that medication use from my clinical practice. And then they had some of that data.
That's yeah, that's handy that there's something for you to build on. I suppose yeah, original as good as original research is, yeah, it needs to start somewhere. So yeah, I'm glad you had these I suppose who ended up being your supervisors were already there ready to go, roaring to go, I bet. But I
I think it was a good
suppose yeah,
way to sort of get your foot in the door because I
yes.
still remember that first week when I started my PhD. You go from this really busy sort of community pharmacy, you're always on the go, you're doing like 100, 150 scripts a day. And then you get there and you're like, I'm not really sure what I'm meant to be doing. Like you're sitting, there's no one like waiting, saying how long till my script is ready. And yeah, so I think having a really sort of clear idea, at least for those first couple of projects, and having some data to get into, and having like supervisors that were like passionate and interested in that area as well. So Rowan Elliott was working at the hospital, so I also had that sort of clinical experience too. It was a good way to sort of transition, I guess, from that really busy clinical work to research work, which is busy in a very different way.
Yeah. And did you find that transition challenging at all, or did you almost welcome it?
I think it's mentally challenging, just sort of trying to adjust to the completely different type of work and the different expectations and that sort of lack of, I guess, immediate tasks that you need to do. So you're always got that, you kind of always know what that next task is in sort of community pharmacy or even doing home medication reviews because you've got to see that next person, you've got to do that next script or but in research, particularly initially when you're sort of coming up with your project and sort of forming that guide of what you're going to do, it's very much of read the literature or talk to these people. And it's kind of hard to, at least initially, know that you're making progress and see the difference and yeah, know that you're not wasting your time.
Fair enough. Yeah. Um, I suppose another thing I was curious to ask as well is, especially since like I do have a passion for research and maybe one day I'll go on to do a PhD too. I know some of my lecturers are already trying to egg me on for it, but I'm thinking when I suppose when you're doing a PhD in pharmacy, what would your typical work week look like, I suppose? Like you said, you'd be reading the literature, talking to these people. But was that constant?
I think it varies quite a lot depending on the stage and depending on the project. So, like some days I would be, for some parts of the PhD, I would be actually in the memory clinic. So, one of my projects was at the memory clinic at the Austin Hospital. So, like 2 days a week, I would be there. I'd be recruiting patients for the pilot study. I'd be talking to the geriatricians. Other days, it might be, with lots of screens open of data analysis and sort of coding and those sort of things. Other days, yeah, it's screening those multiple papers, titles and abstracts and full text for literature reviews. So I think it varies quite a lot. And it varies quite a lot over the sort of course of your PhD as well. I guess my typical week also, so I generally did 4 days a week on my PhD, but I also still worked clinically. So I generally had 1 or 2 days in the community pharmacy and also doing home medication reviews on the side. So that was,
Hmm.
yeah, all sort of happening in that sort of, I guess, 1 week as well.
Jeez, yeah, sounds like it'd be quite um busy and full on, but then that variability in what you had to do each week, I suppose, yeah, keeps you sane because I know working in community pharmacy, it's like you come to work and it's the same thing every single day. You're dispensing scripts and then occasionally you get a weird case and you deal with it. But I suppose, yeah, whilst you're doing a PhD, you're kind of switching face every other day, like you said. You're at Austin Health at one stage working in the memory clinic, and out of curiosity, did you work with a lot of dementia patients there?
Yeah, so we do in that trial. So that was the DPIM trial. We did recruit people living with dementia as well as their carers to participate in that trial. And so we'd be having conversations. I'd do the follow up with them as well to sort of see how they'd gone and whether the medication had changed and how they sort of found the interaction with the pharmacist as part of that trial. I guess in my current research, we do quite a lot of that as well. So at the moment, I'm doing some co-design to develop resources for people living with dementia, their carers and healthcare professionals. So we're doing a lot of sort of interviews to understand their experiences and sort of information needs and that sort of thing with people living with dementia. And we've got sort of like a consumer group, which involves people living with dementia. So have quite a lot of engagement at the moment as well.
Okay, yeah, and that's good. And I think some of our audience members might not be too familiar with like the pathogenesis and what dementia actually is. So, I suppose, how would you explain in layman's terms, if you will, the concept of dementia, especially to those that would be unfamiliar with it?
So I guess dementia is something that affects the brain. And I guess most commonly we think of it as affecting memory and thinking, but it can also affect other things such as mood or behavior. I think most people probably just associate dementia with trouble remembering things, but that can actually vary depending on the type of dementia they have and also the stage of the dementia. And the actual symptoms associated with dementia are a lot broader than just trouble remembering. Some people also think, I guess, it's part of normal aging, which it's not. So it's not a normal part of aging. So I think that's an important distinction to have because a lot of people sort of offhandedly say, oh, I'm getting older, I'm forgetting things. But it's not actually a normal part of aging. And I guess the other part is, which I sort of touched on, is there's not just one type of dementia. So often people use Alzheimer's dementia and dementia sort of interchangeably, but the Alzheimer's is one type of dementia, and there are actually a lot of different forms.
Yeah, because I remember my other grandfather who's not he's not 99, but yeah, I remember hearing he got the diagnosis of vascular dementia, and even though I'd already done a biomed degree, I was like, what was that? I'm like,
Yeah,
never
so
heard of that.
vascular dementia is quite common and also mixed, both vascular and Alzheimer's. So you can have sort of parts of both types of dementia as well, is increasingly common.
Yeah, and I suppose you did talk on some of the misconceptions around dementia. Do you hear or see any kind of false stigmas surrounding these patients that you might want to put a Mythbuster episode on?
Mythbusters. Love that show. Um, I guess, I mean, from a pharmacist perspective and sort of what we see clinically as well as what we're trying to do with research is there's quite a lot of a conception that if a person is living with dementia, they're not able to make any decisions or they shouldn't really be involved in consult like questions about their medicines and decisions should be made without them, which is really just absolutely not true. And so both clinically and in our research, we're really trying to make sure that people living with dementia are involved and are supported to help be part of that conversation. Sometimes that will be together with a substitute decision maker, but as healthcare professionals, we really need to make sure that we are enabling them to be part of that conversation. And that might be providing, simple resources in lay language and large text fonts and those sort of things, having the conversation multiple times about, risks of medications, and sort of constantly checking in with them to see whether those medications do suit their goals of care, for example. And those goals of care do change over time. So it's not about having one conversation just when they're diagnosed with dementia. It's about having sort of those progressive conversations.
I'd imagine that could be quite challenging as well, but I suppose it could be quite rewarding to see those patients progress and do become uh, I suppose, independent, whilst they still can. I was going to ask, do you see, as composed to a patient that wouldn't have dementia, are there any unique challenges, in medication management for these patients, that you've identified in your experience? And as a prospective pharmacist myself, and for those in our audience as well, what kind of approaches would you recommend I use in challenging these patients?
Yeah, I think sometimes the sort of processes or the way we approach things is probably should be used for anyone anyway. So I guess like there are challenges in terms of there's lack of evidence to sort of guide decisions because people living with dementia are often excluded from sort of randomized controlled trials that inform the guidelines and inform the recommendations that all healthcare professionals are trying to follow. There's sometimes challenges I mentioned goals of care a minute ago in terms of trying to identify those goals of care. Like sometimes it can be hard to have those conversations and get them to understand and be able to communicate that back. Sometimes they have different sensitivities to different medications. So, for example, they might be more sensitive to anticholinergic side effects. So there are some considerations, and that can sort of change over time as well as their sort of dementia progresses. But I think it's probably consistent with all older adults is really making sure that you have the right medicine at the right dose for that right person, and really those conversations and not necessarily just using a guideline, but making sure that that guideline can be applied to that individual and that evidence can be applied to that individual. And what And I guess coming back to that, there's different types of dementia. Even people with the same type of dementia won't always have the same symptoms. And it really needs to be that patient-centered care, which is, yeah, relevant for everyone, not just for people living with dementia.
Did that aspect of personalized medicine is definitely it's definitely a forthcoming concept I see being taught in the classroom. Like I'll be asking really specific questions about some of our lecture material, and whilst sometimes it does get dismissed as it's a bit too specific, it's like yeah, but we still have to be able to adapt to look after the patient and not the patient as a demographic, as it will. So, I'm not just looking after dementia patients, I'm looking after Bob, who happens to have dementia. Um,
Exactly. And I think that
yeah,
terminology is really key as well. So it's like we shouldn't say dementia patients, like they are a person. They may happen to have a condition such as dementia, but they are a person. And so really focusing on that and focusing on what that person needs and not on whatever condition they may have is really critical for how we deliver care as a healthcare professional.
yeah, true words have never been spoken, I suppose. But I suppose, yeah, what's some advice you could give me or research fellows out there? How can we work to optimize the health outcomes of dementia patients or individual patients, as you will?
I guess so, like part of it, I think, is looking at what medications they are taking. So there's obviously no cure for dementia at the moment, maybe soon, but not at the moment. So some of it is looking at making sure they've got medications or non-pharmacological things in place to help delay or reduce sort of cognitive decline. So that there's a lot of sort of research in terms of making sure their cardiovascular risk factors are under control and so making sure they're not socially isolated, like those sort of things, which I think particularly community pharmacists that might see their patients more regularly than say other healthcare professionals. I think that can often come up. You can have those conversations and just sort of check in, how are you going? And if they are sort of starting to decline or you're sort of seeing things that might not seem right, like really stepping in and even just having that conversation or referring them to someone like a GP or an allied health person that might be able to help. I think as a researcher, I guess the phrase nothing about us without us sort of comes to mind. And it's really about we make a really conscious effort to ensure that we have consumers involved. So in all our research. So if we are developing a new guideline or a new resource that talks about medication use or medication management strategies for people living with dementia, we have them involved. And I think you can do that as well as a pharmacist. You don't want to come up with the goals of care for someone without actually talking to them about what their goals of care are. So I guess from both of those points, it's really actually talking to the individuals and trying to work with them.
Yeah, yeah. And I suppose, yeah, that the current research that's being undertaken is quite imperative in making sure that, our guidelines can help drive future pharmacists like myself to make sure we can look after the our patients on a personal level. And like you said, we've got to have a conversation with them. What are their goals of therapy, not what are our goals of therapy for them? So I suppose I wanted to talk a bit on your current research though, because I saw the term knowledge brokers and I wasn't 100% familiar with it. So do you want to give a brief explanation on perhaps the role or just overall your current research, I think, surrounding the roles of pharmacists as knowledge brokers in the context of residential aged care?
Yeah, sure. So I guess people might be across the fact that we are having more pharmacist involvement in residential aged care. So we've got sort of the move to have aged care on-site pharmacists. And so I guess a lot of that role is a natural extension of what RMMRs might be doing in terms of those resident level services, medication review, medication reconciliation, those sort of things. But I guess the system level medication optimization potential is perhaps less well known. And I guess that's where a lot of my research is focused at the moment. And I think as pharmacists, we have huge potential to actually make a difference in terms of improving processes, building capacity of staff, building capacity of organizations to actually drive medication safety and drive proactively improvements in medication use. So knowledge brokers is, I guess, my baby at the moment in terms of knowledge broker really is just an individual that helps take information from those that make it. So guideline developers, researchers, to those that actually need to use it and actually apply it in practice. So residential aged care staff, healthcare professionals. And we've been doing a little bit of work in terms of what is a knowledge broker, what do they actually do? I guess there's probably three four things that they do. So one, there's a knowledge manager. So that might be, distributing guidelines, raising awareness about the guidelines, applying that guideline, which might be a national document or even an international document, relevant to that local setting. So relevant to that specific residential aged care facility or home, and looking at, what do we need to do at this particular home to actually put that into practice? Like, what needs to change? What are we concordant with? What are we not concordant with? The second core role is as a linkage agent, which as pharmacists, we're fairly used to that, sort of connecting stakeholders, try to talk to GPs, try to talk to a community pharmacy if you're in the residential aged care home, or if you're talking to the hospital, talking to the carer, like you're already sort of linking people. And in residential aged care, where you often don't have all the healthcare professionals on site at the same time, that's a really critical role, and probably something that may not be as critical in hospital because you often are there on the ward together. And then the third part is as a capacity builder. So obviously recognizing one individual can't change everything themselves, so that one pharmacist can't change everything. They can't be there 24/7. It's really about building the capacity of the organization and of other staff, other healthcare professionals, to support that guideline implementation, support that evidence-based care. And that is education, audit and feedback, looking at barriers and facilitators, those sort of strategies. So at the moment, we're evaluating aged care pharmacists working as this sort of systems level knowledge broker role. We've just had a 12-month trial finish on the 30th of September, so the Embrace trial. We had knowledge brokers at 19 residential aged care homes around Australia, so 4 different states of Australia, implementing the new clinical practice guidelines for the appropriate use of psychotropic medicines in people living with dementia in residential aged care. So that guideline was actually led by our centre, so the Centre for Medicine Use and Safety at Monash University. But rather than just have it sort of on the shelf, the Embrace trial was really looking at strategies to actually actively implement that in practice.
Okay, that sounds quite impressive. And yeah, like you said, it's quite important that we act as, I suppose, a intermediary between our colleagues. Like, yes, in hospitals, I've experienced myself on clinical placements. Like, I can go to the next desk, the doctor's there, the charge nurse is there. I'll see the social worker and the OT walking around, but not everyone's there at the same time in a residential care home. And I know that from not only my grandfather being in a care, well, both my grandfathers being in a care home now, and mum actually working in one now at the moment too. Like I hear borderline horror stories of the kind of barriers that stop the residents from being able to be treated properly, even if it's basic things as conjunctivitis, or even I heard a story about a resident at my mum's home being admitted into the hospital with cellulitis because the doctor wouldn't visit them over the public holiday, you know?
Yeah.
So I suppose as an extension of this, what kind of future roles do you see as pharmacists in making sure these barriers are a bit easier to overcome, especially in the context of homes starting to recruit more nurse practitioners, for example?
Yeah, so I think this systems level role is really the opportunity. So obviously, as all healthcare professionals, if we're doing the resident level roles, it's really important. It's really important. Obviously, I've talked about person-centered care. It's a really important part of the role. However, if we're always sort of, I guess, down in the weeds, always helping those individual residents, we're not sort of seeing the overall process as it could be improved. And if we actually improved that process, maybe it would stop the need to, put that process in place for those 10 individual people, because it would naturally happen. So I think in terms of, work smarter, not harder, I think we need to be actually working at this systems level. We need to be looking at the policies, processes, guidelines, staff awareness, staff capacity to actually do these sort of things. And I think particularly related to medications, pharmacists have the expert knowledge there. We are the ones that can do that. And if we can train those pharmacists to have some of those change management sort of skills, knowledge translation skills, they can really be the advocates or the champions for that sort of role. So we're not going to solve everything, but I mean, if we can provide some of those skills and help sort of get that out into actual practice, those skills are not going to be just relevant for one guideline. They're going to be relevant for any guideline, any new evidence, any new protocol that gets implemented. So I think, it's the way of the future, hopefully.
Yeah, it is pretty exciting as I get to graduate and register pharmacist. I'm excited to see what the workforce looks like when I'm, 2, 3, or 10 years down my career. But I suppose, do you see any other exciting or even just any emerging trends in this field? of practice?
I mean, I think there's a lot of exciting things happening with the pharmacy profession at the moment. Like we're doing so much more than we did when I graduated. And I think, by the time you graduate or 10 years down the track, probably going to not even be recognizable, to be honest. Like we're vaccinating, we're looking, there's prescribing pilots, that's probably going to roll out more frequently. We are working in different settings, so aged care homes, GP clinics. I think it's just expanding so rapidly. It's just really exciting. And I can't even, I guess, predict what we could be doing in 10 years' time, because I think even like in 1 year time, it could change so rapidly that it's just an exciting time to be a pharmacist or be a future pharmacist, I guess.
Yeah, yeah. Even just saying, because I did work at a community pharmacy where they were a pilot site. So they were doing the travel vaccines, and they started doing the continuing supply of the oral contraception. I think they were starting to do the shingles antivirals prescribing, as well as the psoriasis trial. But even just that being permanently implemented in other states, I'm excited because I'm not being taught these sorts of things while I'm at uni. It's that new. So I'm definitely excited to see what sort of roles I'll be able to pick up, because we're definitely encroaching into the realm of what a GP would usually be doing traditionally, or at least, yeah, even my friends not studying pharmacy are surprised that, oh, I can go to the pharmacist for this now. Like they don't even think about going to a pharmacy when they get sick. So I think, yeah, it's exciting to see that there might be a bit more advocacy for pharmacists to, I suppose, take a bigger role in the diagnosis side of medicine, because we have the knowledge and we have the capabilities. And yeah, and if we can get the proper training in anything, whether it be in community, hospital, or in residential care, I think that's, yeah, it's a massive opportunity, and I think we should grab it with both hands. But I suppose we're looking a bit too far forward now. So to bring us back, when you were a student, looking back, or even just when you were doing your PH project as well, what are some of the core lessons or principles that you might want to share with myself and other aspiring students hoping to take a similar path?
Um, I think, I guess, put yourself out there, probably. Like particularly if you're sort of even remotely considering the idea of research, I think just reach out, talk to people, talk to different people, because there's so many different types of research. I think when I was doing my undergraduates, which is a long time ago now, but I guess a lot of the pharmacists that went into research was very much like drug development or sort of mouse experiments. And I don't think we really got exposure to the type of research that like I do now, like this sort of health service, real practical implementation type, changing practice type research. And also a focus on like the impact that that research can have. Like some of my research is being put into actual, like cited in guidelines and sort of being like recognized in sort of government documents and like helping to shape this sort of aged care on-site pharmacist role. And I think the potential that you can have in research is really exciting. But I guess so if you're not sure, if you want to learn more, I think, yeah, probably the advice I have is to actually just reach out. And even if you've already started your PhD, like project, still reach out. Like there's so many different methodologies and so many different research types, different collaborations. And most of us researchers like to talk about our research. So I'm very happy to talk to you, very happy to like spitball ideas about potential projects or potential collaborations. So I think, yeah, if you just reach out, have some conversations and try and, I guess I always had that sort of thirst for knowledge and that desire for change. But if you've got even a little bit of thirst for knowledge, just, yeah, reach out and have those conversations, I guess.
Yeah, it's massively important to put yourself out there, I think, especially in pharmacy in Australia. It's such a small world.
It is.
I think someone knows someone. So yeah, if you get a conversation rolling, you never know, you might be on your PhD pathway. But yeah, otherwise you've achieved a lot. You've achieved a lot. I'll say that I'm impressed massively. So what are the sort of things that made you successful? Was it just putting yourself out there, or was there a bit of putting the elbow grease in, I suppose, as well?
I think there'd be a bit of blood, sweat, and tears, a lot of hard work in there, a lot of passion, which often makes the hard work worth it. But yeah, no, there's definitely a lot of hard work in there. And it's a different type of work, as I mentioned before, in terms of you're not sort of doing 150 scripts a day. It is a different type. It's often a lot quite mentally taxing type research. But as long as you're passionate, you know where you're wanting to head, you know what the potential impact of your research is, I think it makes the work worth it. I am quite passionate about still maintaining that clinical work alongside research work, so they inform each other. Because I don't want to sort of do research that isn't relevant to practice, and I don't want to do clinical practice that is forgetting research. So I guess I think that might have contributed to my success a little bit, just because I am able to sort of bring in both of those thoughts in any of the conversations that I'm having. Yeah, I guess that's probably, yeah, hard work and passion probably. It's probably two key factors.
Yeah, definitely. Yeah, if you, I know I'm very passionate about pharmacy now, and it's definitely made the last 9 months bearable. I'm like, I'm doing this because I like it. Even just, yeah, some of the topics, like, I don't know why I hated kidneys going through my undergrad degree, and I'm like, I'm doing an acute kidney injury this week. I'm like, I'm gonna do it. I'll get through it. I'll try not to fall asleep while I was watching my discoveries, and you know, came out of it. I'm like, oh, this topic's all right actually.
Yeah.
But yeah, but then I hear autoimmune diseases, and I'm like, oh, okay, this is my stuff now. Like, yeah, my passion behind the really niche topics that related to my undergrad, I'm like, okay, I think my passions just that I had from high school have carried on into my undergrad, now into my pharmacy degree. I know it's gonna stay, it's gonna stick. And yeah,
I think
it's
sometimes focusing on that bigger picture can help with some of the finer detail as well. Like if, like the kidney, for example, like so many medications are processed by the kidney, and understanding where they work in the kidney and how like changes in kidney function affect medicines. Like if you can think of the like the end goal, it can bring it back. Some of the passion can bring back to the daily
exactly.
struggles.
Yeah. Finally, I just want to ask, looking back now, is there anything at all you would change? I know talking personally, looking back at the undergrad degrees I did that have led me into pharmacy, even just the subjects I did in VCE, and I changed schools at the end of year 11, which I thought was a radical thing to do at the time. Um, but yeah, I have no regrets thus far. So would you change anything that you've done in the past at all, Amanda?
I don't think so. Like probably in the moment, there's things going, "Oh, I wish I never did this." But I mean, they all help to shape you. They all help to shape your perspectives and your experiences and like how you do things these days, both clinically and in research. So I think it's all been part of a journey, and it is a journey. And I think that's okay. Just recognizing that it is a journey in those moments sometimes is a bit hard. But yeah, no, I don't think I would change anything.
That's yeah, well that's good to hear. I think yeah, definitely in the moment you can be like, oh, why'd I pick this up? I'm not enjoying this, but looking back, it's all part of the experience.
Yeah,
That's for sure. Whether it be studying pharmacy or doing PhD or postdoc research, you know?
yeah.
Yeah, I think that's all we've got time for today. Thank you so much for your time. I feel more educated coming out of this. Definitely have a better appreciation, specifically in and around the research and kind of clinical practice in our aged care homes in Australia. And I think the work you're doing is fantastic and exciting. So I suppose watch this space. Thanks again, Amanda.
Yeah.
Yeah,
Thanks so
enjoy
much
the
for
rest of your
having
day.
me. Yeah, it was
No
really nice
worries.
having a conversation. It was great.
It's a pleasure. All right.
Dose of Pharma acknowledges the traditional custodians of the various lands throughout Australia on which we connect today, and pays respect to elders past, present, and future.